Welcome everybody to the next instalment of Getting to Grips with Genomics, and this week is Lynch Syndrome Explained. I'm very pleased to welcome our co-hosts, South East Genomic Medicine Service Alliance, who are supporting us in this series of talks. And it's my pleasure to welcome Dr Dimitra Repana, oncologist and joint lead of the Lynch Programme in the South East. She works at St George's and is a specialist in colorectal cancer and cancer genomics. She's going to talk to us about why we as GPs are going to be seeing more and more of Lynch syndrome and how we can support our patients and improve even our coding in primary care. So, and also we're going to have a talk from Emma Jenkins. I'm very pleased to welcome Emma. She's a patient who has Lynch syndrome, and she's the rep for the South East Genomic Medicine Service Alliance. And she's going to talk to us about her experience, about how she was diagnosed and how we as GPs can help in understanding Lynch syndrome a bit more. So welcome to them and welcome to you all on a busy Wednesday, I'm sure, taking the time out to dip into something a bit different from our normal primary care workload. So thank you all for joining. I appreciate it. Just a few housekeeping bits. You are being recorded and we will circulate everything with the webinar slides. So no need to worry about taking any screenshots or anything like that. Could I ask you, and already doing a good job, to keep your cameras off and your microphone on mute throughout the session, unless you're the speaker. Pop all questions in the chat box. We will try to answer them all within the webinar, but we'll see how things go. But we will follow up with an email. But anything pre-submitted, we would hope to do in the Q&A at the end. There's also going to be a feedback survey at the end. If you've got your phone and good with QR codes, fantastic. If not, there'll be a link in the chat box. So, without further ado, I'll hand over to Dr Dimitra Repana, oncologist. Take it away. Thank you very much.
Thank you very much, Alex, and thank you very much to the Surrey and Sussex Cancer Alliance for helping us to organize this. So, as it was mentioned, I am an oncologist. I treat bowel cancer and have a background in cancer genomics, and I've been involved with the Lynch Programme for a good few years now. So, I will try in the next half an hour to cover quite a lot. So I will start just with the basics and how mutations result in cancer, because that's really an important introduction so we can understand the genetics behind Lynch syndrome, how we test for Lynch, what are the risks associated with the condition, and what we can do to reduce these risks. And then briefly, I will mention some really interesting research and also the primary care coding at the end. So I will start with this slide that I always use when I do any teaching about genomics. So cancer is a disease of the genome. So you can see here from the left to the right, starting from the fertilized egg, as we grow older, mutations accumulate in our genome. And this is completely normal. It happens because our cells divide many, many times, and these mistakes inevitably will happen. At some point, with the environmental lifestyle exposures, we can have cells that accumulate quite a lot of mutations. So that is towards the right of this figure. And then when we have a certain number of mutations and mutations that affect specific processes in our cells, cancer develops. Now, if someone is born with a mutation, that means that they have a mutation that they have either inherited from their parents, or sometimes we have what we call de novo mutations, so mutations that have occurred in that very first ages of the fertilized egg. This is a germline mutation and will follow that person throughout their lifetime. And these are the two types of mutations that we have in cancer. So the vast majority, 90 to 95%, is what we call a somatic mutation that is present in the cancer. So here is an example of a lung cancer. So we know that smoking results in the accumulation of lots of mutations that unfortunately result in cancer. Now, these mutations could be what we call driver mutations. So these are the ones that are causal in oncogenesis, or they could be passengers, mutations that are just happening because the genome is no longer stable. And these mutations are only present in the tumor and they cannot be inherited. Germline mutations, on the other hand, account for a small proportion of cancers, 5 to 10%. They are present from birth. They are present in all cells, and having a germline mutation results in predisposition of cancer, and that degree of predisposition depends on what is that specific mutation, and they are heritable. So how do we test these mutations? So the somatic mutations are the cancer mutations, so we need a biopsy or the surgical specimen. And something quite modern that we do recently is what we call a liquid biopsy. So we know that cancer cells shed some of their DNA in the blood circulation, so you can collect the DNA and check for mutations. On the other hand, for the germline mutations, you have to extract DNA from lymphocytes, so from normal cells, that is for solid tumors. But when you have a blood cancer, then you need to, obviously your blood cells will not be normal. So in that case, you need either fibroblasts from the skin biopsy or other non-blood specimen like saliva. And important to remember that something that is present in the cancer is not necessarily present in the germline. So unless we do the pair testing, so we do both tumor testing and germline testing, we will not know. So after this introduction, let's explain what is Lynch. So Lynch is an inherited condition. So it's caused by a germline mutation. It results in an increased risk of cancer, and the two main cancers are bowel cancer and endometrial cancer. And when we look at all the bowel endometrial cancers, Lynch is the cause of about 3%. And Lynch is quite common, I'm afraid, and 1 in 400 people in the UK are estimated to have Lynch, but only 5% are aware. And our job in the last few years is to find that missing 95%. So moving on to inheritance. So as we said, this is an inherited condition, and it follows the autosomal dominant pattern. So here we have two parents. One has the mutated gene and the other doesn't. So when we look at their children, there is a 50% chance that their children carry the same gene alteration, and 50% that they do not. And family history is really important for Lynch. So here I'm showing a very representative family history tree of Lynch. So we have here the grandfather that had bowel cancer at 59, 4 children, 2 of them had cancer, 1 endometrial, 1 colon cancer at 42. And when we look at the 3rd generation, the grandchildren, we have a young person only at 37 that had bowel cancer, although their mother did not have cancer. And we have in genetics something called the modified Amsterdam criteria. So when you have 3 or more blood relatives across 2 generations and 1 at least under the age of 50, the likelihood of finding Lynch is up to 85%. So that means that if any of these people here that were not affected by cancer would come to you and they would say that I'm actually a bit worried about my family history, and they should be worried about this family history, they should be referred to genetics for testing. So, and also there are some advantages about this, because sometimes, unfortunately, relatives may have died because of their cancer. So these criteria allows us to test people for Lynch in the absence of living relatives that were affected with cancer. And also, if you have a family history like that, even if we don't find Lynch, and we may not find Lynch, additional screening is also recommended. So I think the take-home message from this slide is that family history is really important, and it should trigger at least a discussion with genetics. Now, I'm going to try and explain the genetics behind gene syndrome, so I do apologize, but I will have to use some genomic terms. So Lynch is caused by mutations, or we call them otherwise pathogenic variants, in one of these 4 genes that are our DNA mismatch repair genes. Now, they are called MLH1, MSH2, MSH6, and PMS2. And also there is a 5th gene called EpCAM that is just next to MSH2. And you have some changes. If you have some changes in the final exons of that gene, it affects MSH2. So if you have these changes in your EpCAM, the phenotype is similar to having a change in MSH2. And what do these genes do? So in this figure, I'm showing a spelling mistake that has happened here in this cell during the DNA replication. So we have an A instead of a G that that would be the normal. So when we have this mismatch repair system and that works well, what they would do is they would remove that A, as you can see here on the right, and they would put a G, and that spelling mistake has been corrected, and now we have a GC. If that mechanism isn't working, then that A stays there, it is not corrected, and that is a mutation that stays there in that cell. So when we don't have this correction mechanism for all these spelling mistakes, the result is that any mutations that are introduced in the cell are not corrected. And as they accumulate, that results in what we call genomic instability and eventually cancer. Now, another genomic term that I will have to introduce is something called microsatellite instability. So microsatellites are these repetitive parts of our genome. So you see here with red, we have AAA, CACA, and we have them in our genome randomly distributed, and that is completely normal. Because they are repetitive, they are prone to mutations because of something called polymerase slippage. So actually there is a higher risk of spelling mistakes in these areas. So when that MMR complex doesn't work and mutations are not corrected, microsatellites are the first areas in our genome that we see mutations. So the MMR complex that doesn't work is the cause, and the result is that we have these mutations in microsatellite instability. And I'm sure many of you receive these terms when you see letters from us oncologists describing bowel cancer and colorectal cancer mostly. So what do we do when we have someone with bowel cancer or endometrial cancer? We check for changes in the MMR system. And the way we do that initial screening, so we all remember this DNA, RNA, protein sequence from our biology. So you check for protein expression on the tumor. So here I have an example of MLH1. So A is the normal, that MLH1 is present. B is the abnormal, that you don't see that brown staining. So this is the immunohistochemistry staining for MLH1, and this is abnormal. So at this stage, we know that there is a protein, there is an issue with the protein. So, and that is a very easy way to check cancer. We can also check for microsatellite instability. So we do a PCR to check for mutations in these specific areas called microsatellites. And this is the initial screening that we do in all cancers now, all bowel cancers, endometrial cancers. And at this stage, we don't know if someone has Lynch syndrome. All we know is that on these cancer cells, we have either what we call MMR deficiency or microsatellite instability, depending on which method we use. And this is the final term I will introduce, something called MLH1 promoter methylation. So here I'm showing our DNA, and our DNA normally would have these methyl groups attached to it, and then it's packed into histones and chromosomes. In cancer, we have something called hypermethylation. So we have lots of these methyl groups, and that results in gene inactivation. So MLH1 is one that is affected, so the part of the promoter of MLH1. So when you will have hypermethylation, then the gene is inactivated, but the actual gene is intact. So this is what we call an epigenetic feature, and it is not inherited, and it is consistent with a sporadic tumor. So having introduced all of these terms, let's look at what we do for all new colorectal endometrial cancers. So our pathologists will do either test for microsatellite instability or MMR deficiency. There is very high concordance, so each hospital can choose and each lab can choose what to do. And then at this stage, for the abnormal results, we may need to do this extra testing with MLH1 promoter methylation testing, and about 70 to 8% of these results, that hypermethylation will be present and nothing further is needed. And then at the end, we have these patients that we have done all the testing in the tumor. We know that there is an indication of Lynch, and these are the people that will now need to have genetic testing so we can confirm Lynch syndrome. So before we do that genetic testing, we cannot say that someone has Lynch syndrome. And as we discussed earlier, this will be done in a blood sample, usually. Now, the part of the testing has been complete, and we know that someone has confirmed Lynch syndrome. So unfortunately, that translates into an increased risk of cancer. Colorectal endometrial are the most common types, but there are other gynec cancers like ovarian, endocervical. Then we have urological cancers, cancer of the uterus, cancer of the renal pelvis, prostate cancer, upper GI cancers, cholangiocarcinoma, small bowel cancer, gastric cancer, and then we have pancreatic cancer, and then a small risk of glioblastoma, which is a brain tumor, and multiple sebaceous tumors, which are tumors of the sebaceous glands. And most of the times they are benign. Here on the right, you see on the left, you see benign tumors, but rarely they can be cancerous. This is the figure on the right. And 75% of the cancers of the sebaceous carcinoma are around the eye, and the rest are in the head, neck, trunk, and genital area. Generally, these are quite rare, but it's something we need to remember when someone has Lynch syndrome. And the risk of all of these cancers varies depending on the gene that is affected. So I'll just see here, I have with pink the female and with blue the male risk. And you can see, for example, for colorectal cancer, if you are a carrier of MLH1 or MSH2, your risk is much higher. If you are a carrier of MSH6 or PMS2, the risk is lower. And of course, with none of these mutations, your risk is not 100%. So not everyone with Lynch will have cancer during their lifetime, and that is something very important to share with patients. It's very different with some other genetic conditions. For example, if you have familial adenomatous polyposis, your risk of bowel cancer by the age of 40 is 100%. So not everyone will develop cancer, and which gene is affected actually plays a significant role. If someone could choose, you want to have the PMS2 gene that is associated with a slightly increased risk of colorectal cancer, endometrial cancer, and the rest of the cancers, the risk is similar to population. So when we, at genetics, when we see someone with Lynch, we use these tables that have been produced by the UK cancer genetics groups, and I have the link at the bottom, and they will give you an estimate of the risk of developing a cancer by the age of 75 compared to the population risk by the same age. And all this information is being collected for years and years, and there is something called a prospective Lynch syndrome database that it's not just the UK, but quite a few countries that collect information. At the bottom here, you see how the risk of cancer changes depending on the age. So if we take, for example, the risk of bowel cancer for men, for MLH1, it's 3% by the age of 30, and then increases to 15% by the age of 40. If we look at the risk of endometrial cancer, no cases have been reported, at least in the information we have available so far, by the age of 30, but that risk increases to 2% by the age of 40. So this is really important, so we can define our screening strategies. And here I have put here these tables for all the genes for MSH2, again, for Lynch carriers versus the population screening and according to age, MSH6, and finally PMS2. And you see here, for example, that for bowel cancer, the risk by the age of 30 is less than 1%, and it starts increasing to 1% by the age of 40. So these are the risks of cancer associated with Lynch. So let's see now what we can do to reduce these risks. Colorectal cancer, as we said, will not happen to everyone with Lynch, but it's very important to screen for it. So we suggest a colonoscopy every 2 years, and we start at age 25 for the MLH1, MSH2, and EPCAM carriers, and 10 years later for MSH6 and PMS2, based on the data we just saw about the risk of cancer according to age. Now, this is screening. There are ways to reduce the risk of cancer, and I will talk about all of these: aspirin and lifestyle modifications and H. pylori screening. Then we have risk-reducing interventions like a prophylactic hysterectomy and bilateral salpingo-oophorectomy. And I'll discuss a little bit about pre-implantation genetic screening. And finally, as an oncologist, I really need to know if someone has Lynch syndrome, or even if they don't have Lynch syndrome, but they have these genomic features, the MMR deficiency or microsatellite instability in their cancer, because this will change our management. And with the introduction of immunotherapy in the last few years, we are really seeing some amazing results, and we can talk about cure for some people that have a stage 4 cancer. So it's really, really important, and we wouldn't really start any oncology treatment plan without knowing this information. So let's start with the colonoscopies. So we have a Lynch National Bowel Cancer Screening Program. This was introduced in July 2023, and that was one of the aims of the National Lynch Transformation Project. And now we have a national registry, so we know all of these people in the UK that have Lynch syndrome, and this is going to really change the management of these patients. So when we diagnose someone with Lynch, it's the responsibility of cancer genetics to refer patients for colonoscopies via the national program. And the main advantages is that they have a robust system to call people every 2 years. And they offer a high quality procedure. So as we said, we start at age 25 for MLH1, MSH2, and EPCAM, and age 35 for the other 2 genes. And the recommendation is that at 75, there is a review. And as you probably know better than us, people at 75 can have lots of other issues that a colonoscopy may be the last thing they need. So there is a review at 75. The benefits of having regular screening for bowel cancer are really important. So the risk of bowel cancer is reduced by 40 to 60%, and the risk of dying from bowel cancer by 50%. And Newton did this trial a few years ago. Published this paper that they showed that if you have regular colonoscopies for Lynch compared to not having, this translates into a 7-year survival benefit. So there is a huge benefit there. Now, the National Lynch Programme has a free helpline, and I have put here the number. And patients and health professionals can actually ask if their patients have been included. At Genetics, every 3 months, we get the list from the National Bowel Screening Programme, and we compare with the ones we have diagnosed. So we also check. But if you have a patient that wants to know when their next colonoscopy is, they can always call this number. And if someone is over the age of 75, they can also request screening by calling the free helpline. So NICE has developed a very nice leaflet about the colonoscopies for the Lynch Programme, and I have put here the link for this. And it's something that we do share with patients as well when they are diagnosed. Now, moving on to other ways to reduce the risk, one of them is aspirin. So the CAP2 trial was completed several years ago, and we have long-term data now. So patients were randomized to take either 600 milligrams of aspirin once daily or a placebo. And what the trial showed was that if you take this high dose of aspirin for at least 2 years, your risk of bowel cancer is halved, and that risk reduction starts to be evident after 4 years from the initiation of aspirin. The trial didn't show any benefit for other Lynch-related cancers, and very importantly, when the adverse events were compared, they were not statistically different than the placebo arm. So even this high dose of aspirin was safe according to the trial. So what we recommend now, so after that trial, there was more evidence that lower doses of aspirin are also effective. So the UK Cancer Genetics Groups currently recommends 150 milligrams once daily for those that weigh less than 70 kg, or 300 milligrams once daily for those that weigh more than 70 kg. And the recommendation is that aspirin should be started for those that are Lynch carriers after the age of 18 until the age of 60, when there are no contraindications. Now, there is a little bit of a debate there, and it's something that is going to be addressed very soon, and we're hoping that we will publish some more guidance about the age that aspirin should be finished. But we definitely don't recommend that anyone over the age of 70 should start high-dose aspirin, because we know that the risk of side effects increases. Before starting aspirin, it is recommended that we check for H. pylori and eradicate if necessary. And the optimal duration of aspirin is really not known. There is a lot of research going on. What we do know is that if you take it for at least 2 years, there is a benefit, and we think that a longer duration is likely beneficial, but we're still collecting data about that. Very soon, we will have the results of the CAP3 trial. So the 5-year follow-ups were completed this summer, and we expect the results next year. So in this trial, lower doses of aspirin, so lower than the 600, were used. And we are hoping that the trial will show that the low doses are much safe, are equally effective. And we know that it's much easier to suggest to someone to take 100 milligrams of aspirin than 600. So we will know more soon. So in summary about aspirin, and I fully appreciate that we don't have the full picture yet, is that if there are no contraindications, Lynch carriers should start aspirin with this dose that I have put here, 150 or 300, depending on the weight, for at least 2 years. And then as long as they do not have any side effects, they can carry on, but not beyond the age of 70. I have here the recommendations from the UK Cancer Genetics Group and the patient decision aid that has been produced that from NICE that you can give, we give to people before when we discuss aspirin. Now, moving on to lifestyle modification. So when someone has Lynch, there is a genetic predisposition to develop cancer. So it makes sense that we try to minimize the effect of all the other factors that we know are associated with an increased cancer, risk of cancer anyway, regardless of having a Lynch condition. So we recommend a healthy diet with lots of fiber, and I'm going to talk about resistant starch in a moment. We recommend to maintain a healthy weight, and currently there is a lot of discussion among genetics because now we have these new drugs that can help people lose weight, and whether this is something that should be recommended for people that have genetic conditions that increase the risk of cancer. So hopefully we will learn about this soon, and there, we need more evidence, but it's something that we will definitely be discussing in a few years. So we recommend regular exercise, smoking cessation, and minimize alcohol intake. And resistant starch I just mentioned. So the CAP2 trial with the aspirin also had an arm that people were randomized to add to their food a sachet of resistant starch that was a powder, or a placebo powder, and they would do that for 2 years. And what the trial showed was that the risk of non-colorectal Lynch-related cancers was also reduced by half. And you don't really need to get the powder for resistant starch. Resistant starch is found in many foods. So I have here, you see a lot of beans, lentils, underripe bananas, a potato salad that, so essentially resistant starch is found in potatoes that have been cooked and then they have cooled down. And we do recommend that people, Lynch carriers eat lots of these foods. And currently a group of dietitians is preparing some specific guidance about amounts that people should eat. And, just thinking as an oncologist that treats bowel cancer, if changes in our diet can reduce the risk of cancer in people that have a genetic predisposition, I can only imagine how much benefit there would be for people that do not have a genetic predisposition. So, it's really important that we recommend this diet. We're learning so much now about the microbiome, and I think this is something that will definitely change the risk of cancers in the future. So Professor Byrne was the one that led the CAP2 trials, and he has a blog that he regularly updates. So I have put the link here at the end. Now, moving on to the risk of gynae cancers. So women are referred to gynae to discuss the pros and cons of risk reducing total hysterectomy and bilateral salpingo oophorectomy. So the age that this is recommended is when they have completed their families and no earlier than the age of 35 to 40. Now, the timing should be individualized. So there may be some women that want to do this earlier if they have completed their family. We also need to take into consideration their family history. So in some families, you may see that cancers develop earlier or later, the menopause stages and comorbidities. For PMS2 carriers, we do not have the risk of ovarian cancer, so these women are referred for a postmenopausal hysterectomy because the risk of endometrial cancer before the age of 50 is very, very small. And then if you have had the operation, HRT can be offered until the age of 51, or until they wish to stop, and always in consultation with their specialist. Now, pre-implantation genetic testing. So this is something that is can be offered to Lynch carriers. So they can go through IVF, and we can do genetic testing in the embryos and then decide whether they want to transfer embryos that carry the mutation or not. These are discussions that should always be done with a genetic counselor or a geneticist, and then they are referred to specialist centers that do this pre-implantation testing. There are a lot of ethical considerations here, and these are decisions that are not easy, and they should always be done in specialist centers. I have here a link about embryo testing, and I just want to mention here one of the questions before the meeting was what we should advise to people that they want to do these genetic testing via commercially available or over the internet. So the recommendation would be that these are very important decisions. All testing should always be done in an accredited lab, and also something really important is that that lab also has either a genetic counselor or a geneticist that can advise accordingly. And we've had a few cases, really sad cases, that people were given very wrong information with tests that weren't really robust, and actually the repeat tests were very different when they were done in a proper lab. So I would just say that we need to be very careful about things that do not have the correct accreditation. Now, other recommendations. So we know that H. pylori increases the risk of gastric cancer in general. So for people with Lynch, we recommend that they have that one-off screening, and also we recommend it before starting aspirin. Now, in terms of screening, women should participate in the NHS cervical screening, and that is not different. And then for MLH1 and MSH2 carriers, the pros and cons of prostate cancer screening should be discussed with their GP. There is no other evidence-based screening that is available for all the other types of cancer associated with the risk syndrome, because nothing has really been proven that improves outcomes. We always recommend symptom awareness and a dermatology assessment if there are any suspicious skin lesions. And very importantly, we recommend a low threshold to have investigations if there are any red flag symptoms. Now, there is psychological support available, and the Lynch Syndrome UK has a patient support group, and I have here the link. In our experience, most people usually adapt to this information, but support is available if needed. And then testing relatives. So first-degree relatives have a 50% risk of having Lynch syndrome. So testing is recommended after the age of 18, when someone can understand and consent. And also, this is an adult onset condition, so testing before the age 18 is not recommended. And this is what we give to Lynch carriers, so they can give it to their relatives. So this is a letter that says that your relative had genetic testing. This is what we found. This is the change, what we found. And we recommend that they take this letter to their GP and they request to be referred to their local genetic service. And the testing is done via genetics. We call this predictive testing, and we test for that specific variant that was found in the family. Now, another question that we're being asked is about insurance. So there is currently an agreement between the government and the Association of British Insurance, and they should not require or pressure people to have any sort of genetic testing, and they cannot ask for the results of any genetic testing that you had, with the only exception of life insurance over this amount and only for Huntington's disease. So I spoke to one of my patients recently that had knew that his sister had Lynch syndrome and didn't want to be tested because he was worried about insurance, unfortunately developed cancer, and now we have confirmed that also he had Lynch. So we do include all this information when we meet patients, but if someone asks, this is what they should be advised. And I have here the link. Now, very briefly about the National Lynch Transformation Project. So we said that only 5 people are aware in the UK. This is what we estimated in 2018. And this work was led by the Bowel Cancer UK charity. And there has been significant progress since then. So here I have the MMR testing for colorectal cancer in 2019 and then in 2023 on the right. And you can see now that we are screening more than 90% of people for colorectal cancer, and then endometrial cancer, similar numbers, more than 90% of patients that have endometrial cancer receive that initial testing with MMR. Very importantly, we're trying to reduce the time to receive a Lynch diagnosis. So in 2021, it was estimated that from the time someone is diagnosed with cancer, it takes about 310 days until they are offered germline testing. And with the introduction of mainstreaming, which means that testing is being moved to the local cancer teams, we can reduce that time to 7 days. And the final quadrant of 23-24, 46% of colorectal teams and 41% of endometrial teams in the country were using a mainstream model. So we're not only trying to identify people with Lynch, but we're trying to do that as quickly as possible so they can have access to these risk-reducing interventions. Very briefly about some really interesting research. So we're looking at novel screening methods. So checking the urine, incorporating fit tests to colonoscopies, the use of AI. There is a lot of qualitative research, and with Lynch, we have had the pleasure of working with many patients to understand what they really need. And very recently, you may have heard that a vaccine is in development. This is the team in Oxford that is working on this. They currently got funding to continue their work. So we're very hopeful that in a few years, we will actually have a vaccine to reduce the risk of cancer in Lynch carriers. And finally, about primary care coding. So when we had the meeting, when the national program finished, and that was March 2024, at that time there wasn't a code available, but now there is a code for Lynch syndrome, a SNOMED code, and then a code for family history of Lynch syndrome. So it is very important that that GPs know who, if their patient has Lynch, and also if their patients are at risk of Lynch. So one of my patients was, very worried that her children might not get being tested because in a few years' time, unfortunately, she was diagnosed with cancer. She didn't know if she would be around, and she was really worried. So I think these codes, and currently we don't have a national consensus how to use these codes, but they are available, and they can be used to remind, for example, if someone has Lynch, to have a low threshold to start investigations for any red flag syndromes, or knowing that this patient is at risk, this person is at risk for Lynch, and at some point they would need testing. So to summarize, Lynch syndrome is an inherited condition that is associated with an increased risk of cancer. A family history of cancer should prompt a referral to genetics, regardless of investigations or diagnosis of cancer. Genetics will refer for colonoscopies. They will provide recommendations. We send a very long letter when someone is diagnosed with Lynch, covering all the things I mentioned. And they also provide lifelong support. So we have what we call an open door policy. So patients can get in touch and we can discuss about any of their concerns. Symptom awareness is very important, both for patients but also for their GPs, and a low threshold for investigations. Aspirin can reduce the risk of bowel cancer. These female carriers may need to have surgery, and HRT can be offered. And then their relatives need to have predictive testing if this is something they want to. And then we, as I said, we now have a national Lynch registry, so we're trying to coordinate that there is equity of management and access for all patients around the country. Now, how to refer? So I have here the 2 genetic services. So Surrey and Sussex is mostly covered by St George's, by us. So I have here our email, our website that has forms and any information that is necessary, and our number. And then there are a few hospitals that Guy's and St Thomas's is the original genetic service. So I have here their email, website and phone. And finally, I have here some useful links. So there's some training from the Genomics education program. So if you look at the Surrey and Sussex Cancer Alliance website, they have very useful information. There is online training specifically designed from primary care. And then there is information from charities, the Eve Appeal and the Lynch Syndrome UK. So that was my final slide. I will stop sharing and I will invite Emma Jenkins, who I have the pleasure of working with her in the South East GMSA. So Emma has Lynch syndrome and she has been really helpful, you know, telling us what people with Lynch need, and has helped us a lot about the patient experience survey that we have been running. So Emma.
Thank you so much, Dimitra, and thank you so much for inviting me along today. I do genuinely consider it a privilege to talk to people who are making a difference to people like me who are living with an inherited condition. So I'm mindful of time, so I'll whip through things. But if you want to find out more about the story of my father, my dad, and myself, there is a podcast which you can see on the screen, which I'm sure we can pop into the chat or the minutes, that mean that you can hear that story in full. But in short, my dad developed a cough in 2007, which seemed fairly innocuous, didn't really think too much about it. And then the cough just seemed to continue and continue and continue. And after a little bit of persuasion, he went to the doctor. And when he was there, the doctor sort of said, oh, it's a cough. And after some back and forth, it was then decided that Dad would go for a blood test to try and source what, whether there was an underlying issue. And it was discovered that he had anemia, and it was that anemia that was causing the cough. And then with further testing, it was discovered that he had a colorectal tumour. And it was during the pathology of that tumour, it was discovered that he had Lynch syndrome and he had inherited PMS2. So it was at that point, although it was a long time ago, so we're sort of talking 16, 17 years ago, it was encouraged that my brother and I go along for testing, along with my dad's brother and his side of the family. And it was something where my brother and I didn't disagree, but we had different perspectives, my brother being younger than me. But I felt that the test was something I really wanted to do, because my understanding was that if I was tested and I found I didn't have Lynch, that's one thing. But if I was discovered to have Lynch, it would mean that I would be able to receive regular surveillance. And my belief was surely it would be much better to have some polyps maybe removed or something small taken away, rather than potentially wait a long time, especially if you don't have very obvious symptoms. So in 2008, I went to Guy's Hospital, where I had the most wonderful genetics counsellor who really explained the process. And we sat down and we looked at family history. And my father's mum had, or my dad's mum had colorectal cancer. And that was in the 70s, when genetic testing wasn't something that was freely available. And I often wonder, and I know my dad does, what his life might have looked like if he'd have had the opportunity to be tested from an earlier age. So I had the test and we looked, and I had blood taken. It was at that point where I was told that I had 2 weeks to decide whether I would like the test to take place. And that was really important because it was a head and heart issue, that the hospital were very clear with me that I would, although I had an understanding about what the genetics testing was, it was important for me to go away and think about the implications either way, whether I have Lynch or whether I don't, because there is an emotional toll that knowing you have something, even if you never develop cancer, there is that emotional toll with regard to knowing that you potentially have a condition, or the guilt that comes with not having that condition, for example. So I decided, yeah, I definitely want the test, and I considered things around insurance, and it's great to see what Dimitra was talking about, the improvements around that understanding with insurance now, because that was something I was very worried about as I was just before my 30th birthday. And then I received the letter that said, yes, you have Lynch, and it then gave you some really scary statistics. I'm a very heart-led person. My dad's a medical physicist, so we interpreted the data very differently. But it was the first time I'd seen him cry ever. Well, no, that's a lie. It was the second time I'd seen him cry. But it was because he felt guilty that he'd given something to me. And that's something I can't underestimate or overestimate to all of you, is that although this is my story, you will often find that guilt can be associated with something that's completely out of these people's control, like my lovely dad. So we talked about what that meant, and they talked about the regular colonoscopies that I would have, and my dad completely demystified those. And we have even a little tip book about what makes taking Plenview or Moviprep bearable, which is glorious, because you tend to, I think the brain sort of filters out certain things after 2 years. So it's great to have those tips at your disposal. But for me, as I was before my 30th birthday, there were big concerns with regard to the issue around preventative hysterectomies. And at that time, 16 years ago, I was told I should consider a full hysterectomy when I was 40. And that was kind of it. I was then left for 10 years. So I was regularly having the colonoscopies. But then when I hit 40, I suddenly thought, what do I do? Do I speak to someone? Do I go to my GP? Will they understand what I'm asking? Am I being am I overestimating or underestimating what I need to do in terms of personal responsibility? So again, for me, one of the reasons I wanted to get involved with the GMSA and wonderful people like Dimitra is that if we can talk more about Lynch, what it is, what it isn't, if we can demystify more things, and if we can talk to more people so that they're aware of the changes that they can make to their lives, it empowers patients like myself to come and talk to you. You have busy enough jobs. You need to know that if we're coming to you with a concern, it is grounded in some sort of information that we have discovered from reputable sources, such as the NHS or the Genetic Service. So for me, I really wanted to come along today to say that, yes, I'm one person, and do listen to the podcast if you think it's useful. Kelly, who is one of the genetic consultants, is fascinating to listen to, just like Dimitra. But for me, one of the reasons I wanted to come along is to say to you thank you, but also to say that for me as a patient, and from talking to other people who are living with Lynch, whether that be after a cancer diagnosis or through familial links, is that it's really important that we get this conversation about Lynch going. Sadly, from my personal perspective, when we find out about difficult conditions or difficult illnesses or diseases, it's come at the tragic expense of someone losing a life. And I'm talking about that also in terms of popular culture and celebrities. Obviously, my generation, it was the Jade Goody effect. Sadly, more people went for their smear tests because of Jade. Those numbers fluctuate, and sadly, it often takes something awful happening for more people to become empowered to take control of not their destiny, but I wanted to know what I had so that I could make those modifications and have surveillance so that I would be in the best fighting chance to live a long and happy life. So talking about it is really important. I think as well, for me, talking to lots of people, there is also a concern from some GPs that they have to pay for the genetics testing. And I think it's really important that GPs and other primary healthcare professionals understand that that cost is not their responsibility. It is picked up through the NHS programme, because Again, that potentially, if you're not understanding what Lynch is and the implications, it might potentially stop someone referring. And I know I'm not saying that's any of you, but I know that's experience from talking to other people living with Lynch. And also what is involved. So my brother is now about to go down the line of being tested, but he's meeting a little bit of resistance with his GP at the moment, because the GP has said that he can't have the genetic testing referral until he has had a colonoscopy. So for me, that understanding of what the genetics process is and what the testing process is really, really important. The last two things, the coding for me is really important, because that low level threshold, it might mean that someone who's presenting with anemia, like my dad, it might be that, yes, they might have a B12 deficiency or something like that. But also it might mean that it's some cancer, either recurring or somewhere else in the body. So that the coding is so important for me, and looking at our GP records to see whether Lynch is even mentioned near the top. So that if we are coming in with something, anybody who's accessing our records will know that Lynch is something we are living with, and it might have an implication in terms of our surveillance or treatment, so that everything that you're looking at doing, the referrals are more nuanced based on our inherited condition. And the final thing is to just remember the patient behind the diagnosis. It is a real head and heart thing. As much as I try to be a grown-up at nearly 50, sometimes I do find it can be quite overwhelming, especially when acronyms are thrown out there. And it's really important for patients to realise that there are reputable, reliable sources out there, not just social media, because the picture of Lynch, not just in the southeast, but in the UK, compared to people who are living with Lynch in other countries, can be very different. So for me, it's about making sure the messages are correct, timely, and that patients like myself are supporting you to do the best that you can do to help us, but help us to be the best that we can be to help you. So I hope that was in time for some questions, and I'm sorry that was fast, but do take a look at the podcast if you're making a cup of tea, doing a bit of an ironing, going out for a walk, because it will tell you a little bit more about my family story. Thank you.
Thank you, Emma. We have a couple of minutes just for questions. So Emma, if you can share, could you share your top tips for colonoscopy?
Actually, the bizarre thing with a colonoscopy is that it's often the thought of it is worse than it actually is. And I often use humour to deflect. But in terms of the preparation, science has made great strides, but Movi prep tastes horrific, especially the second litre. So little tips that we've discovered is definitely chilling it. We have a 4-straw rule. And I'm afraid not great for the environment. We don't use plastic, but we use cardboard. 4 straws to the back of the tongue, because then actually the solution isn't touching the tongue, it's just going down the back of the throat. We also found that although you're encouraged to have clear solutions, such as apple juice, we find the more savoury side of things helps, because the solution is quite salty. So that can be an issue. And the other real top tip, and my dad told me this on my very first colonoscopy, and I didn't believe him, is you won't feel that you need to go to the toilet, but go to the toilet. And I know that sounds very crude. I won't tell you what happens next, but basically my dad was right. Yeah, you don't feel like you need to go, but you certainly do. So I'm more than happy to talk to anyone about any of the top tips. So Stephanie, I can see your comment. I'll send you an email.
Excellent. So, I mean, we have 1 minute. So very quickly, I will just answer a few questions from the chat. So aspirin beyond 2 years. Yes, absolutely. The trial did have 2 years of aspirin, but people could continue. And we think that more than 2 years is better. So if someone is fine and well, they should carry on. There is another question about the testing. So MMR testing or MSI testing, we do it in the initial biopsy. So the question is about frail patients that can't have surgery. So if they have a cancer diagnosis and we have some tissue left even from an initial biopsy, we would be able to test. If we're not able to test, then based on the family history, there may be recommendations. And then does omeprazole reduces the risk? There is currently no evidence that having omeprazole with aspirin will change anything, and it's not recommended. And we don't have evidence that it would diminish the effectiveness of aspirin as well. And then there was one more question about aspirin and colorectal cancer. So we know that aspirin in general reduces the risk of colorectal cancer. There is a lot of evidence there. Aspirin is an anti-inflammatory drug. There is a pathway called PI3K, and we think that this is the way it works. So, but there is still a lot of work that is being done on the role of aspirin. There is a trial now that in the UK that people, after we have completed that and we're waiting for the results, people that had a bowel cancer or other cancer diagnosis take aspirin, so we can see if the risk of cancer is reduced as well. I think I covered all of these questions, but if there are any questions, more than happy to reply them after the event. I'm very sorry, Alex, we did overrun.
No worries at all. Thank you, Dimitri and Emma. That was really fantastic. And don't worry about the timings at all, but I will wrap things up. Dimitri, thank you. Incredibly comprehensive, and it's amazing how many people, how common this is, 1 in 400, and yet only 5%. We absolutely need to get this conversation going, like you said, Emma. And great steps in bringing down that timing from 310 days to 7 days is fantastic. So yeah, we absolutely need to get this going. And I think this was a really good introduction. I've certainly taken a lot of learning, and hopefully, well, it's a double-edged sword, but hopefully I will get coding more and asking the question and knowing more about it. And Emma, just a real thanks to you. It's really powerful when we have patients on board, and you articulated everything so well, and it really lands closely to GPs as to why we're doing this and how we can do it better. So we will get this conversation going. I'm really glad to see good numbers on this, and hopefully this will trickle out to others. And yes, movie prep support I think is a winner. So I will leave you be. There was a QR code if you wanted to scan that. Otherwise, feedback, I think there was a link going in the chat. Otherwise, I will leave you be to your busy days. I hope you took something from that. I certainly did. And thank you again to our speakers. Really super. Take care all, and cheerio. Hopefully see you again soon.
Bye.